Good afternoon, everyone. Pediatric Center of Excellence, KSCH, New Delhi, welcomes all the participants for today's RDLS session. Today's topic is pediatric clinical case presentations, and the speaker is Dr. Harshita Gosainwal. Dr. Harshita ma'am is currently working as the medical officer with the ARD Center at Kalavati Saran Children's Hospital, that is KSCH, New Delhi. We welcome you, ma'am, for today's session and request you to start the session.
Good afternoon, everyone. Shweta, is the screen visible?
Yeah,
Clear?
screen is visible, ma'am. You're audible.
Okay. Good afternoon, everyone. I am Dr. Harshita Gosainwal, Medical Officer at PCOE ART Center KCH. Today, I'll be taking a RDLS on the session Pediatric Clinical Case Presentations. So, for today's session, what are the objectives? We'll understand treatment failure in CLHIV, challenges in sustaining long-term viral load suppression. We'll understand what is a substitution or and a switch. We will go about the revised viral load testing algorithms. We'll also go on enhanced adherence counseling, that is EAC sessions, disclosure of HIV status to CLHIV. Then on the last topic, it is clinical case discussions. So treatment failure in CLHIV, there is despite optimal adherence. CLHIV on long duration of ART, despite optimal adherence, may also develop treatment failure. What are the causes? There is accumulation of drug-resistant mutation resulting from unusually higher viral higher application rate. There is error-prone reverse transcriptase, and it is naturally due to selective pressure from drugs or from the immune system. So when should a CLHIV to be referred for PCSF? CLHIV with suspected ARV treatment failure, with suspected moderate to severe ARV adverse drug effect or ADR, with drug-related complication or management of severe OIs, that is opportunistic infection, from the private sector on a regime other than preferred regime under NACP or NACO. So the decision for initiation of third-line ART shall be taken by PCSF at PCOE or selected ART plus center after e-review only. So it is a very important point to be noted. जब आपको थर्ड लाइन शुरू करनी है तो आपको पी से सब करना है इधर एट पीसीओई और अपने सिलेक्टेड एआरटी प्लस सेंटर में. So, how do you define a treatment failure? There are three types of treatment failure. One is virological, second is immunological, third is clinical failure. When do we say it is a virological failure? When viral load values of more than 1,000 copies or unsuppressed with the following criteria. That is, the CLHIV should be on ART for at least 6 months, and after 3 sessions of EAC with adherence of more than 95% consecutively for last 3 months or after EAC 2, that is enhanced adherence counseling session 2. So, what is immunological failure? There are three categories depending upon the age of the child. So, when the children is between 12 to 35 years of month, when the CD4 percentage falls below 15%, or the percentage persistent CD4 levels below 200 cells after 12, after 12 months of ART. So for the children 36 to 59 months, when the CD4 percentage fall below 10%, the persistent CD4 levels below 200 cells. Now for the children aged 5 years and above, at least one of the following three criteria should be there. There should be fall of CD4 count to pre-therapy level, 50% fall from peak on treatment level. There should be persistent CD4 level below 100 cells after 12 months of ART. Now, how do we define a clinical failure? When there is a new or recurrent WHO stage 4 condition that could be extrapulmonary TB or CMV retinitis or cryptococcal meningitis infection after at least 6 months of ART, or there should be progressive neurodevelopment deteriorating or a growth failure. So, in this, there are three types of treatment failure. One is virological, immunological, and clinical failure. So now there are few points to be noted. When there is a concomitant or recent infection may cause a treatment decline in CD4 cell count. The condition must be differentiated from IRIS, that is immune reconstitution inflammatory syndrome. Some WHO states 3 and 4 conditions like TB lymph node, pulmonary TB, uncomplicated TB pleural effusion disease. Esophageal candidiasis or recurrent bacterial pneumonia may not indicate treatment failure. So, when to suspect a treatment failure in CLHIV? There should be factors to consider before failure of the existing treatment regime is concluded. The child should have received the regimen for at least 6 months. Adherence to the therapy should be assessed and should be optimal. That is, adherence should be more than 95. Any active opportunistic infection should have been treated and resolved before interpreting CD4 counts. Immune reconstitution inflammatory syndrome, that is IRIS, must be excluded. Primary malnutrition that can mimic clinical treatment failure should be ruled out. The adverse effect of drug manifesting like clinical treatment failure should be ruled out. All suspected clinical and immunological failure should be confirmed by virological criteria for treatment failure. Review whether ARV dosage are as per the current weight band and optimize dosage if inadequate dosage has been prescribed. So from the graph, you can see the chronology of treatment failure. Now, if you can see the child CLHIV, the child is failing on ARV drugs. So first we can see we can detect it by viral load detection, and then there is immunological detection, and last we can see the clinical detection. So why should we do the viral load testing? Viral load provides an early and more accurate indication of treatment failure and the need to switch to second line or third line ARV. This helps reduce the accumulation of drug-resistant mutation and improves clinical outcomes of all PLHIV or CLHIV on ART. Measuring viral load can also help distinguish between treatment failure and the non-adherence. So there is important point to be noted. The pharmacological option for second line ART in children are very limited due to non-availability of pediatric formulations of many ARV drugs. And second is perinatal exposure to the ARV drugs. There's importance to support and promote the factors that facilitate and sustain the response to the first line ART regime as long as possible. So, what are the challenges we face for sustaining long-time virological suppression in children? There is unusually high baseline viral load before starting ART. There is intrauterine and perinatal exposure to ARVs, immature or developing immune system, dependency on caregiver for adherent support, dynamic dosing with weight. There is non-availability of child-friendly formulation. So now we'll go about the case. There are 10 case studies. We'll go on the presentation. So case study one says there is Master V infected with HIV, age around 14 years, presented with oral candidiasis, severe wasting and stunting. His CD4 count is 3. The TB screening was done, which was negative. So he was started on first line ART. On that time, that was zidovudine, lamivudine, and efavirenz. 4 months later, he presented with behavior changes, that is agitation, for around 2 to 3 months and severe headache, vomiting for 2 to 3 days. So, comment on the new onset of symptom. Is it a new opportunistic infection? Is it a adverse drug reaction? Is it iris or it's a treatment failure? I would like everyone to put their answers in chat box. Nishata, is the chat box visible?
Ma'am, it's visible to me, waiting for answers.
Okay.
Requesting participants to please put their comments or responses in the chat box. Ma'am, if you know any medical officers, you'll have to call out names.
Okay. From ARTC LLRM merit, if medical officer is there on this thing,
Kiran sir, can we?
anybody can answer.
Mic access has been given to all. You can also unmute and answer the question. Ma'am, we'll continue with the session.
Okay. So the answer is
Could it be
the
Iris?
MRI.
Iris?
Yeah, you're correct. It is a iris. So MRI revealed multiple tuberculoma in the brain. We did the repeat CD4 count that was 100. From 3, it raised to 100. A new event developed after 4 months of starting ART and had also shown partial immunological recovery, raised CD4 count. It is diagnosed as TB iris, not as a treatment failure. Anti-treatment was started for this child along with steroids. His ART was continued and adherence to therapy was emphasized. Also, do not consider this as treatment failure because the duration of first-line ART was less than 6 months. So we'll understand what is a substitution and a switch. So how is substitution different from a switch? Any change of ARVs prescribed should be carefully distinguished between substitution or drug within a given regimen and switching an entire regime. So we'll discuss first about substitution. Substitution is single drug replacement. मतलब इसमें एक single drug replace होगी, not all the three drugs. In the current ARV regimen, following adverse drug reaction or any drug-drug interactions or intolerance refers to substitution, and it means that an alternate first-line ART regime has been prescribed, not the switch. This does not mean the pill HIV is put on second-line ART, even though second-line drugs, example boosted PIs, may be used. So substitution is always single drug replacement in the current ARV regime. Now, what does switch indicate? It indicates the entire regimen is changed due to treatment failure that can be virological or immunological. Treatment failure is due to loss of antiviral efficacy of the ongoing ART regimen. In treatment failure, there is a switch of entire regime from first to second line regimen or from second to third line. So substitution is a single drug replacement and switch is switching of the entire regimen. So you can see on the slide substitution or a transition. So the zidovudine, lamivudine, lopinavir is substituted with zidovudine, lamivudine, and DTG. You can see from lopinavir, we have switched to DTG, substituted to, sorry. And from abacavir, lamivudine, DTG, we have substituted is to TLD, that is tenofovir, lamivudine, and DTG. In this, you can see the abacavir has been substituted or transitioned to tenofovir. And the third one, the abacavir, lamivudine, and lopinavir is substituted to abacavir, lamivudine, and DTG. So in this, the lopinavir is transitioned to DTG. And in the last one, the abacavir, lamivudine, and DTG, that is ALD, has been substituted or transitioned to zidovudine, lamivudine, and DTG, that is ZLDTG. So in the all the slides, in all the cases, you can see only one drug is substituted. That is called a substitution. That is, in the first, the lopinavir is substituted to DTG, and in the second one, abacavir is substituted or transitioned to tenofovir. In the third one, the lopinavir is substituted or transitioned to dolutegravir, and in the last one, the abacavir is substituted or transitioned to zidovudine. For all the PLHIV or CLHIV transition that is substituted or switched, viral load test to be conducted at 6 months, 12 months, and then annually in patients on the first line, and every 6 months for patients on second line and third line. It is very important point. फर्स्ट लाइन के पेशेंट को अगर आप सब्स्टिट्यूट या स्विच करते हो तो उसका वायरल लोड 6 मंथ्स पे करना है आपको, फिर 12 मंथ्स में करना है, फिर एनुअली जैसे आप करते हो. पर सेकेंड लाइन और थर्ड लाइन पेशेंट्स के लिए आपको एवरी 6 मंथ्स करना है. So now we'll go on the second case study. A 4-year, 8-month-old female child is initiated on regime ALE, that is abacavir, lamivudine, and efavirenz. And that time, her viral load were raised in spite of her adherence being more than 95%. Her plasma viral load, you can see it's around more than 4 lakhs, and then around 2 lakh 36,000, and then around 3 lakh 54,000 after even step-up counseling sessions. Her recent weighs were 14.3 kg, and the CD4 count was 772, and percentage was 27. Child had repeated episodes of acute gastroenteritis during the ALE regime. So, will you switch over second line ART or you continue the same regime? If yes, what regimen would you switch over to? I would like the answers in chat box or they can unmute the mic. Anybody know any answer about this question?
A mic access has been given to all. Ma'am, we can continue.
We can continue. Okay. So in this case study, so hence the child was referred for PCOE. This child has treatment failure as a viral load testing shows. The opportunistic infection worker was advised in view of repeated episodes of AGE and TTG to rule out celiac disease. Once all the opportunistic infections are ruled out, we will switch the child to second line treatment available, that was ZL plus lopinavir with ritonavir. As a child weight was 14.3 kgs, ensuring that the patient is clinically stable and ensuring hemoglobin levels are more than 9 gram per deciliter. There should be strict monitoring of hemoglobin, should be done at 15 days from starting the second line ART, 1 month, 3 months, and then 6 monthly after initiating the ART. The step up adherence counseling was also done. A repeat viral load was done after switch, which showed virological suppression. Her viral load was TND and the CD4 count was 447 and percentage was 32. So, as per the NACO guidelines, when the child was started on ALE, it showed treatment failure. There were three virological viral load which were raised. So, according to this PCSUP referral, the child was switched to ZL plus lopinavir with ritonavir. And we should check for the hemoglobin. It should be more than 9 gram per deciliter. And when the DTG 10 mg was introduced in the program, her viral load was suppressed, that was TND, and the child was transitioned to zidovudine, lamivudine plus DTG. In this, we are transitioning. We are changing the lopinavir from DTG. We are not changing the whole regime. So we are transitioning in the second regime only. We are not putting the child in third line regimen. So after the transition to zidovudine, lamivudine plus DTG, her viral load was TND. So from the slide, the first line ART of the child was ALE. Then after there was virological failure in the child, we substituted to child with ZL8PVR. And when the DTG 10 mg was introduced, as a child weighs of 14.3 kgs, her viral load was done before transition or substitution, and it was TND. We transitioned the child to zidovudine, lamivudine plus DTZ. So, viral load testing. So, plasma viral load is recommended as a preferred monitoring tool to assess ART response and identify the confirmed treatment failure. So, what are the timing of viral load tests? The PLHIV on first line ART. The viral load testing should be done at 6 months and 12 months after ART initiation and thereafter annually. So, first line के लिए हमें कोई भी ART viral load should be done at 6 months. उसके बाद we'll do at 12 months and then we'll do annually. So remember, first line के लिए हम 6 months में करेंगे, फिर 12 months में करेंगे after ART initiation. उसके बाद हम हर साल या annually करेंगे. PLHIV or CLHIV, those who are on second line or third line ART, viral load testing should be done every 6 months after initiation of second line or third line ART. सेकेंड लाइन के लिए हम हर 6 महीने में करेंगे, सेकेंड लाइन और थर्ड लाइन के पेशेंट्स के लिए. And very important point to be noted, all the PLHIV or CLHIV transition that is substituted or switched should be done at 6 months, 12 months, and then annually in patients on the first line, and every 6 months for the patient on second line or third line ART. Plasma viral load testing is recommended for all HIV positive pregnant women during 32 to 36 weeks of pregnancy, regardless of the ART duration, to determine the risk of HIV transmission to the baby. So, this is the new viral load testing algorithm. So, we'll conduct a viral load test at the scheduled duration. If the viral load count is less than 1000 copies, we'll continue the same regime, ART regime, and we'll do the routine monitoring testing. That is, for first line, we'll do annually, and for second and third line, we'll do every 6 monthly. Now, if you conduct a viral load testing in the same algorithm, if the viral load comes out to be more than 1,000 copies, your counselor is to provide enhanced adherence counseling for the patient for at least 3 months, the EAC 1. And if after the EAC 1 session, the adherence is less than 95% in last 3 months, you will provide the enhanced adherence counseling session 2 to the patient for 3 months through a different counselor under the supervision of medical officer or the senior medical officer. So remember this, EAC 1 का जो सेशन है वो एक काउंसलर करेगा, एएसी टू का सेशन दूसरा काउंसलर करेगा, बट एएसी वन के जो तीनों सेशंस होंगे वो सेम काउंसलर करेगा, और एएसी टू का सेशन का जो डिफरेंट काउंसलर है वही तीनों सेशन लेगा. Now, if you conduct a viral load testing, irrespective of the after EAC 2 session, you have to conduct viral load testing irrespective of adherence level. If you see अगर viral load 1,000 copies से कम है और unsuppressed है, we'll continue the same ART and routine monitoring testing. If the viral load is more than 1,000 copies, we'll do a CSUP or a PCSUP e-referral for further evaluation. Now, हमने ये देखा कि if the adherence is less than 95% in EAC1. Now, if in EAC1 the adherence in last 3 months is 95%, you'll conduct a viral load testing. If the viral load count is less than 1,000 copies or suppressed, sorry, we'll continue the same ART regimen and routine monitoring testing. And if a viral load is more than 1,000 copies or unsuppressed, we do a e-referral to CSUP or PCSUP for the further evaluation. So this is the new viral load testing algorithm which has come into the program. So barriers of it is a continuation from the previous slide. That is, the barriers of poor adherence should be identified and addressed during the EAC by the counselor under the supervision of SMO or the MO of ART center. Involvement of senior medical officer or the medical officer to ensure right from the beginning of EAC to look into issues such as any clinical condition, concomitant medication, and partial adherence. Counselor to ensure regular follow-ups of patient to ensure adherence on ART. PLHIV or the CLHIV undergoing EAC2 should be rigorously follow up by the ART counselor through phone calls, and also seek support of CAC, that is a phone call or a home visit, for follow-up of such cases to ensure treatment adherence. CSAP is expected to look into and understand the reason for poor adherence or any other clinical reason for unsuppressed viral load to avoid unnecessary switch to other regimen, including interaction with the patient if required. So now, how do we do adherence counseling and disclosure? What are the factors which affect the child adherence to the ART? So there will be two factors. One is the child related and other is the caregiver or the parent related. First, we'll study about the child issues. The child elected factor, dependency on the adults. मतलब कोई बड़ा खिलाएगा दवाई, दादी नानी मम्मी पापा बुआ वगैरह कोई भी दवाई खिलाता है. Likes and dislike for the medications. Like उसका taste अच्छा नहीं है, उसका smell अच्छा नहीं है, medicine का color अच्छा नहीं है. There can be emotional issues with the child. Like child can say, मेरे सारे स्कूल में जैसे फ्रेंड्स हैं वो तो दवाई नहीं खाते, मैं अलग से क्यों दवाई खा रहा हूँ. यूजिंग मेडिसिन टू मैनिपुलेट अडल्ट्स, कि मम्मी ने या फिर केयर गिवर ने दवाई दे दी है बट उनको बोलना कि मैंने दवाई खा ली है लेकिन दवाई खाई नहीं है, बच्चे ने कहीं साइड में रख दी या फेंक दी. अदर इन्फेक्शंस और medications. Now, there are caregiver related factors. There is knowledge and understanding of treatment and its implication. Like a caregiver has a little knowledge or do not understand the treatment and its implication. Misconception regarding the treatment. Like we have seen in many patients, many CLHIV, if a child is having a fever, loose stool, cough, or any other infection, mother would give a medication for fever, cough, cold, loose stool, but the mother or caregiver will not give ARV medications. Because she says कि मैम बहुत ज्यादा दवाई खाने का हो गया था तो मैं नहीं दे पाई अपने बच्चे को. So there are health beliefs and there is daily routine. Like some caregivers, there are parents who are both working or they go to the job, nature and timing of the job. Attitude towards the adherence. This is very important. There are sometimes in caregiver or a parent does not know about the adherence. What is adherence and how do we make the child adherent to ART? There is repeated changes in caregivers, relationship with the that is the relationship with the child. So at sometimes there is a issue like mother is not there, the father is giving, the father does not know the proper dosing. Sometimes the child is orphan, there is other caregiver like bua, dadi, mama or mami. They do not know the whole matlab, how to give dosing to the child. Or there are children who are living in NGOs. They are having change in caregivers. There are sometimes there are other caregiver coming up in the visit. There in the next visit there is some other caregiver coming. So, what is adherence monitoring? So, there are the checklists for the treatment adherence. First is on time pill pickup. That is, whatever the date given by the medical officer and the senior medical officer, the patient should come on time pill pickup. Second, there is number of doses missed since the last visit. Whether doses are taken at correct time interval, like some drugs to be taken in the morning, that is supposedly you say there is child is on abacavir plus lamivudine 60/30 pediatric population formulation, and the child is taking two tablet in the morning and two tablet in the evening. The parent or the caregiver has not made a proper time. Like in the morning they're giving child two tablet around 10 o'clock, and at night they're giving it around 6 o'clock. So there is no correct time interval between it. So if not, you need to ask about delay in hours. There should be a reason for missing or incorrect dosing or non-adherence to the ART. There should be timing and dosage of concurrent medications. So you need to check adherence at every visit, even if the patient is coming for follow visit or a testing. So there are two sources to check adherence. One is pill count and how many tablets are missed. So what is a pill count? How many pills were remaining in the bottle in the last visit? How many pills were issued last time? Now, how many pills are there in this bottle? On what day was he supposed to come? So everybody knows how to calculate adherence in percentage. So there is total number of pills the patient has actually taken. If you divide it by total number of pills that the patient should have taken in that period and multiply by 100, that will give you the adherence. Or you can do the number of pills given to the client on that day the patient was coming, number of the pill balance in that bottle on that visit, and if you divide it by if you subtract both of them and then you divide by number of pills the client should have taken and you multiply by 100, this will give you the adherence. So let us suppose we'll take an example. The patient last visit, one pill was remaining. एक गोली उस patient के पास बची थी. There are 30 pills of TLD issued in the last visit. So the total pill the patient has, 30 pill उसको dispense हुई थी, एक pill उसके पास बची हुई थी. So there are total 31 tablets with the patient. Now patient comes on day 30 with three tablets remaining. So how do we calculate adherence by the formula? So patient के पास जब वो last visit में आया था उसके पास एक pill बची थी, 30 pills हमने TLD और इशू कर दी, तो वो 31 tablets उसके पास टोटल थी. अब डे 30 पे पेशेंट हमारे पास आता है और उसमें 3 tablets are remaining. So the last visit, one pill was remaining. So the 30 pills of TLD issued in the last visit was 31. Now the patient comes on 30 with three tablets. So the adherence is patient had so the number of pills given to the client were 31. From this formula you can see, and number of pill balance in the bottle is 4, because we'll count the day 30 also. So there is 28 divided by 30. If you multiply by 100, that the adherence will come out to be 90%. So this is the step-up adherence counseling form, which has come with a new viral load testing algorithm. So there is session 1, session 2, and session 3 for EAC 1 session, EAC 1 enhanced adherence counseling 1 session, and similarly we will do in EAC 2 also. So in the form you can see there is uh, ART number, ART regime, date of ART initiation, date of viral load, and every detail is mentioned. There are barriers, intervention, what we did. Everything is mentioned. Everybody will must be having this form. So in this, the important point to be noted is in all the PLHIV with unsuppressed viral load, EAC1 has to be conducted, and in PLHIV with adherence less than 95% during EAC1, EAC2 will have to be conducted. So what is a step-up adherence counseling in CLHIV? You initiate the process of disclosure if not already started. A minimum of 3 sessions are recommended for step-up adherence counseling. All counseling sessions are to be taken preferably by the same counselor. This is a very important point कि जो भी adherence counseling करेगा, enhanced adherence counseling, वो same counselor करेगा. Both the caregiver and the child should be counseled together and individually in all sessions. Counselor needs to review all the barriers that led to poor adherence and provide customized counseling. A customized adherence plan should be developed with involvement of both the caregiver and the child. You should also ensure weight documentation in white card and green book on each visit and check if the correct dose is given as per the weight band. So, what are the general guidance you need to follow? A minimum of 3 sessions are recommended for step up adherence counseling. All counseling sessions are to be taken preferably by the same counselor. Both caregiver and the child should be counseled together and individually in all the sessions. Counselors need to review all the barriers that led to poor adherence and provide the customized counseling for the caregiver and the child. A customized adherence plan should be developed. The assessment of mental health of the caregiver and the child and timely referral appropriate management should be done. So we'll go about disclosure. See, in children, we cannot disclose fully to the child. Disclosure is a very complex process. It is an ongoing process. It's not like कि आप एक visit में बता दो कि आपको ये इस चीज के लिए आप दवाई खा रहे हो. It is an ongoing process. Timely disclosure helps the child to develop a better understanding of HIV and has benefits such as there is improved adherence to medicines, there is reduced psychological distress, there is increased likelihood of appropriate disclosures to the other, there is better engagement in HIV related care. So the timing of disclosure to the child cannot be a universal date or a age. जैसे हमने पहले बोला था डिस्क्लोजर एक ऑनगोइंग प्रोसेस है. हम उसमें ये डिसाइड नहीं कर सकते कि हमें बच्चे को कब बताना है. हम एक स्पेसिफिक डेट या एज डिसाइड नहीं कर सकते. Disclosure of the HIV status is a continuous and a progressive process. Disclosure should follow a planned process with levels of disclosure over the time. Caregivers and all children aged 5 years or more should start being prepared for the disclosure. So there are two disclosure layers. One is partial disclosure that is around 6 to 9 years and full disclosure that is around 10 to 12 years. So there are the two process you can say or a scheduled disclosure process you can say. First you'll do a partial disclosure that is around 6 to 9 years and around 10 to 12 years you'll do a full disclosure. So, how to disclose the HIV status to the child? Use cultural and age appropriate explanation and avoid using the word or term HIV or AIDS. Break down the information to child level. Use interactive communication strategies. You can use flip charts. You can use a multimedia. Repeat concept over time. Repeatedly initiate health-related conversations with child. Always be prepared for child's reaction. Disclosure, remember this disclosure is an ongoing process. So, how do we explain about HIV and ART to the children? Like if a child is 3 to 6 years old, you can see from the face the child is very sad. You can see, you can tell child you are not well. If you want to play, you should be well, and for that you need to take medications. Like आपकी तबीयत ठीक नहीं है, आपको अच्छे से खेलना है, स्कूल में अच्छे से रहना है, तो आपको ये दवाई लेनी चाहिए. Around 3 to 6 years, like if a child is taking ART, you can tell child about the HIV and ART to the children like this. And if the child is around 6 to 9 years, you have got a germ inside. हिंदी में से बोलते हैं कीटाणु या इन्फेक्शन है आपकी बॉडी के अंदर. That germ is making you fall sick often. To kill that germ, you will need to take medicine every day. The germ will become strong if you don't take medication. And around 9 to 12 years, you can see there is a germ in our body. It reduces our body's ability to fight against other infection. We cannot remove it from your body, but we can control it so that you can stay healthy. For that, you must take medications regularly. So in this, you can say, according to the age, we are telling the child about the HIV and ART to children. So what are the key counseling issues related to the disclosure? So question number one, I would like to ask everyone, at what age should disclosure be made? And anybody could answer this question?
Initiation 3 to 6 years.
Mm. So in this, so answer is it is usually, as you said, it is begin informing the children about their HIV status when they are between 5 to 7 years of age. It depends upon the child's ability to understand. With the parent, caregivers, guardian consent, one should do this gradually until the child is 12 to 14 years of age. Now the second question is who should tell the child about the HIV status? I would like to ask everybody. Somebody can answer. मतलब डिस्क्लोजर के बारे में डिस्क्लोज करना किसको चाहिए मतलब बच्चे को डिस्क्लोज अगर आपको करना है तो किसने करना है anybody could answer yeah Dr. Aziz has said very correctly the caregiver so answer is parent or a caregiver it can or it may seek the support of counselor or a doctor as the child grow the understanding of the disease changes there is short term and long term effects of disclosure must be monitored during counseling. It is a continuous psychological support should be provided to the child. So in this, we can see the child should be disclosed about the HIV status by the parents. It can help or seek support from a counselor and the doctor. So now we'll go to the case third. In this, the child has failed on both protease inhibitors and as well as the NRTIs based regimen. That is efavirenz or a nevirapine based regimen. A 8-year-old child was referred to PCSF for review for suspected second-line ART. Sorry. Child initiated on zidovudine, lamivudine plus lopinavir and ritonavir at the age of 1 year and 8 months at that time. Her regime, his or her regime was switched to second-line ART, that was abacavir, lamivudine, and efavirenz. So in this, you can see we are switching the child, we're switching the child regime, not only a single drug. It is not a substitution; it is switch. At the age of 4 years, due to the virological failure, the viral load at that time before switch was around 13,000 and 54,000. 1 year later, the child was again referred for persistent unsuppressed viral load. The viral load after the switch was 15,000 and 13,000. Her CD4 count was 259, 24%. Her recent weight was 11.7 kgs. The child was asymptomatic and adherence being 95%. So in this, you can see from zidovudine, the child was switched to abacavir, and from the lopinavir, ritonavir, the child was switched to efavirenz, as the child was in virological failure. And after 1 year, the child viral load will again raise. So how do we go about it in this case? Anybody would like to answer?
First, we have to ensure that age appropriate dosage of the medicine is appropriate.
Okay, so you will switch the child to third line ART or you will continue the same regime in this?
Good afternoon, ma'am.
Good
Since the
afternoon.
viral load
Oh,
decreasing trend, we can definitely ask the caregiver and the child also counsel. We can counsel the child for adherence, and
okay.
probably
Any,
we can wait for another 3 months or 6 months for the child if the child is not symptomatic.
okay. Anybody else would like to answer on this? So as both the doctors have said, it is correct. You will continue the child on the same regime, that is abacavir, lamivudine, efavirenz. So since the child had failed on both available ART drugs during that time, for a age and weight band, it was decided to refer the case for NASEP to consider the patient for drug-resistant testing, if available. The NASEP recommendation was continue the current second-line regime yearly and ensure good adherence. And during that time, when the child reaches body weight of 20 kgs, regime to be switched to DTG-based regimen. So when the DTG 10 mg was introduced in the program, the child was transitioned to abacavir, lamivudine plus DTG because the child being weight being less than 20 kgs. The child viral load was testing was done after 6 months of transition which was suppressed or TLD. So from this case, you can see the child is failing on both protease-based inhibitor regime and the efavirenz or an nevirapine-based regime. During that time, we'll continue the same regime. As you can see, the viral load trend is decreasing. We'll tell child about, we'll ensure there is a good adherence. And when the DTG-10NG had come in the program, we transitioned the child to abacavir, lamivudine, and DTG. And we did a repeat viral load testing after 6 months of transition, which was suppressed. So now we'll go to the case 4. There is 10-year-old male child referred to CSER with history of virological failure. The child was initiated on ZLE-based regime since 7 years. After initial good adherence, child was lost to follow for a year due to the social issue. When he re-entered into the ART service, there was severe respiratory infection, that is PCP infection. CD4 count was 77. The viral load was 8 lakh around. The step-up counseling was done, and the treatment of acute OI, opportunistic infection, were done. ART was restarted with the same regimen, that is ZLE, zidovudine, lamivudine, and efavirenz. So after 3 months, the adherence improved. The viral load was the adherence were improved, but the viral load was 3,27,000. The CD4 count was 108. Hence, the child was referred to PCSUB. So in the PCSUB, the child had treatment failure, the adherence being more than 95%. So the panel recommended a switch to second line ART that was available according to our weight was abacavir, lamivudine, and dolutegravir. So in this case, we will switch the child to second line ART as there was adherence in spite being more than 95%. The child was not virologically suppressed. So we substituted the child to ALD. The step-up adherence counseling was done. There was repeat viral load testing done after 6 months after switch, which showed virological suppression. Her viral load was 947. The CD4 count was 655 and the count was 30%. So for the second line regime in children, you can see from the table, as this child was on zidovudine, lamivudine, and efavirenz, and the weight band of the child was 14.24 kgs. So we switched the child to ALD, abacavir, lamivudine, and dolutegravir. Now we'll go to the case study 5. A 9-year boy was referred for review by PCSF. The child was initiated on abacavir, lamivudine, and lopinavir-ritonavir at the age of 2 years. Child's viral load were raised, that was about 80,000 and 8,000 at the age of 7 years. He was referred for PCSF and was switched to second line ART, that was zidovudine, lamivudine, efavirenz available at that time, with close monitoring of his hemoglobin's level. At the age of 9 years, his repeat viral load was done, which was unsuppressed again. That was 2,693 and 1,783 in spite of his adherence being 95%. So in this case, you can see there is a 9-year-old boy, which was reviewed by PCSF. This was started on AL LPVR at the age of 2 years. Even after the being on this therapy for 5 years, last 5 years, the viral load was raised, which was 80,000 and 8,000. He was referred for PCSF again and was switched to second line ART, that was ZLE, available at that time with a close monitoring of his hemoglobin level. So at the 9 years of age, we repeated his viral load testing, which was unsuppressed again, in spite of his adherence being more than 95%. So the child was referred for PCSF. Anybody would like to answer to this question? That we'll switch this child or we'll continue on the same regime? Anybody would like to answer that you'll put the child on third line or you'll continue the same regime in spite adherence being 95% and step-up adherence counseling was done for this child? Any answers in the chat box, Shweta?
Continue same treatment.
Okay. So the answer for this, we will not continue the child on the same treatment because even after his adherence being more than 95%, his viral load is unsuppressed. So the PCSF decided, the CSF panel decided the child has treatment failure in spite of being adherence more than 95%. He was switched to third line ART, that was zidovudine, lopinavir, ritonavir plus DTG at the age of 9 years. So in this, we'll switch the child to ZL LPVR plus DTG. There should be strict hemoglobin monitoring and rigorous adherence counseling to the caregivers. His repeat viral load was done at 6 months after switch, which showed the virological suppression. The load was TND. So in this case, we will switch the child to third line ART. So now we'll go to the case 6. In the case 6, there is a 14-year-old girl who was initiated on zidovudine, lamivudine, and nevirapine ART at 3 years and 9 months of age. She was substituted to ZLE because in the view of new onset of pulmonary COX at the age of 4 years, her CD4 count being 951 and percentage being 25%, she was again substituted to ZLN as her ATT course was completed at the age of 5 years. Now the child became lost to follow-up for 6 months. Her TB workup was done, which came out to be negative. The CT test was performed, which was suggestive of chronic collapse or consolidation in lower lobe with bronchiectasis changes. Her ART Zetalin was reinitiated at the 8 years of age. Her viral load was done, which came out to be 39,000, and her CD4 count is 592 and 29%. So, what will you do in this case? Anybody would like to answer the question?
And ESC1.
Okay. So, this is correct answer. So, hence the child child was referred in this. Excuse me, I'm so sorry. So in this case, we have done the adherence counseling also. Even after that, the viral load was unsuppressed. So the child was referred to PCSF, and the panel recommended a switch to second line ART, that was AL plus LPVR plus ritonavir. Her weight being 20.9 kgs at the age of 9 years. Her step-up adherence counseling was done again. The child became lost to follow-up again for 4 years after switching to second line. A TB workup was done, which was negative. The PCP workup was also negative. A CT just shows follow-up case of bronchiectasis and in the previous CT. The CD4 count has been decreased to 159. The case was discussed in the TB clinic and was advised to restart her ART and rigorous counseling for the chest physiotherapy. She was reinitiated on ART, AL plus GTG, her weight being more than 28.3 kg as per the NACO guidelines that time, at the age of 14 years of age. Her viral load is 2 lakhs and her CD4 count is 210. So in this case, the child was referred to PCSF. The child has treatment failure probably due to the poor adherence. As the child is becoming lost to follow up again and again, the child, due to social issue or any other issue, due to the poor adherence, the child is failing. So the panel recommended to continue the same ART regimen, EL plus GTG, as there are very limited or very less ARV formulation available for the pediatric population. There should be a vigorous step-up counseling, step-up adherence counseling should be done of the caregivers and the child. We should ask about the, first of all, the disclosure. Is the child being partially disclosed, fully disclosed, or the child is not disclosed? There should be, according to CSAP committee, the drug sensitivity testing for ARV drug was advised at that time. The repeat viral load should be done after 3 months, ensuring the adherence should be 95%. So her repeat viral load was done with adherence counseling and step-up counseling, with asking about the disclosure. The repeat viral load was suppressed. She is now transitioned to TLD, her weight being more than 30 kgs and viral load TND, CD4 being 514 and 28% at the age of 15 years because her weight was 30 kgs and the viral load was TND. So we transitioned the child to TLD. I'm so sorry. Now it is a case 7, we can go. There are multiple NRTI exposure to these children. A 15-year-old girl was referred for review by PCSF. The child was initiated on zidovudine, lamivudine, and nevirapine. Her baseline CD4 was 35 and percentage of 4%. 1 year later, the child developed zidovudine-induced anemia with a CD4 count being 98 and 12%. The child was substituted to abacavir, lamivudine, and nevirapine because in zidovudine-induced anemia, you cannot continue the child on zidovudine because the child will have severe anemia and can go into the failure. And the adherence was done, which was less than 80%. 3 years post ART initiation, the child developed tuberculosis. The regimen was modified to abacavir, lamivudine, and efavirenz because when the child is diagnosed with TB from nevirapine, we substitute the child to efavirenz. Her viral load was done, which was 9 lakhs, and around 3 years, the viral load was 10 lakhs. Her CD4 count were done, which was 42 6 percentage and 9 1%. The current weight of the child is 22 kgs. So the PCSF recommended switching the regime to second-line ART. You in this we re-challenge the zidovudine, that is zidovudine plus lamivudine plus DTG with close monitoring of hemoglobin every month. So the follow viral load done was done in January 2022, which was 5 lakh. The child was again referred back to PCOE with history of pain, abdomen, loose stool, and hepatosplenomegaly. There was evidence of bone marrow suppression, so her regime was changed to lopinavir plus ritonavir plus dolutegravir BD and abacavir plus lamivudine. That is AL plus DTG plus lopinavir. So in this you can see there are multiple NRTI exposure. Like the child was in firstly was on ZLN, then due to anemia the child was substituted to ZLN. Now the child had developed TB tuberculosis. The child was switched on efavirenz. So you can see there is child was on zidovudine, abacavir, nevirapine, efavirenz. So there is multiple NRTI exposure. So in this, we re-challenged the child in zidovudine, lamivudine, and dolutegravir because the child weight was less than 30 kgs. We cannot switch or transition the child to tenofovir. So we had re-challenged the drug zidovudine, lamivudine, and DTG, and we need to do a close hemoglobin monitoring. And if there's hemoglobin less than 9 gram per deciliter, there is no change in regime till anemia is corrected. Then change to zidovudine, lamivudine plus DTG. And in this, if anemia is persisting or reappears, in this you can see the viral load was done in the month of January, which is still raised. The child was referred back to PCOE, and here you can see there is history of pain, abdomen, loose stool, hepatosplenomegaly. The workup was done. The child had shown evidence of bone marrow suppression. So the regime was changed to lopinavir, DTG, bacavir plus lamivudine. In this slide, you can also see if anemia is persisting or reappears after the rechallenge of zidovudine in this. So we have substituted. Change the drug to DTG lopinavir plus recycled non-zidovudine based NRTI backbone. So this is very important case because in this you have effectively moved the child into the third line regime. Hence, adherence should be carefully monitored and supported. Because after this, we don't have any drugs available for the pediatric or even for the adult formulation. So this is very important point to be noted that we have effectively moved the child into third line. We need to carefully do the adherence monitoring and support that child. In case number 8, we move to case number 8. That is a 2 year, 8 months old child was referred to PCSF for the review for severe drug reaction due to abacavir plus the zidovudine. So in this case, we'll study about the adverse drug reaction, that is abacavir hypersensitivity and zidovudine-induced anemia. So the child was initially initiated on zidovudine, lamivudine, and DTG 10 mg at the age of 1 year, 8 months. So her regime was substituted to zidovudine, lamivudine, and dolutegravir at the age of 1 year, 8 months in the view of abacavir hypersensitivity reaction. In this, it's a very important point to be noted when the child has abacavir hypersensitivity reaction, you cannot re-challenge abacavir because child will have severe failure. The patient developed severe anemia due to zidovudine, so the ART of the child was held. A recent viral load was done During this, the viral load came out to be 209 copies, and the CD4 count is 622, 19%. The weight was 11.8 kgs. So in this case, you can see there is a drug reaction to the abacavir and zidovudine, both the drugs. Now the child was discussed in pieces of and
इसके
decision was made. Hello.
वो कहाँ है मनाली में हैं क्यों वो क्यों नहीं
Child was discussed
हैं
in pieces of and decision was made to
तो तू
refer
क्या करती
NISAB for the expert opinion on optimum ART regime in view of abacavir hypersensitivity and zidovudine-induced anemia. And the child weight being less than 30 kg, we cannot substitute or switch the child to tenofovir-based drug. The NASAB recommends that as abacavir and zidovudine cannot be rechallenged due to the severe ADR or the adverse drug reaction, and there is a limited drug option available for the pediatric age group, we will switch the child to second-line ART, that is dolutegravir plus lopinavir, ritonavir. This was available in the program, so we switched the child to DTG plus lopinavir. Now we go about in the ninth case, that is HIV TB with first line failure. So it is an 11-year-old child was referred to PCSF, suspected first line failure. Child was initiated on abacavir, lamivudine, lopinavir plus ritonavir 3 years back. In September 2023, the child viral load was high. He was also diagnosed with extrapulmonary tuberculosis. The viral load was 66,000 and 85,000 around. The CD4 count is 373, weight being 17 kgs. Now the child was referred to PCSF for the review. The PCSF recommended switch to second line ART, that was zidovudine, lamivudine, twice daily as per the weight band, plus DTG 10 mg twice daily as per the weight band. So the child was initially on abacavir, lamivudine, and lopinavir, ritonavir. The child viral load was high, and child was also diagnosed with pulmonary tuberculosis. The viral load being 66,000 and 85,000, and the child's weight being 17 kgs. We will switch the child to second-line ART, that is zidovudine, lamivudine, twice daily according to the weight band, plus the DTG 10 mg tablet twice daily as per the weight band. So there are two ART regimens like DTG in first case DTG based regimen. You need to double the dose of DTG. Either it is a 10 mg or a 50 mg. You need to double the dose of DTG. Or even if the child is on TLD, like if the child is more than 30 weight band, you need to double the dose of DTG. DTG dose to remain twice daily for 2 weeks after the last dose of rifampicin. And you need to continue DTG dose twice daily for 2 weeks, even after the last dose of rifampicin. And if a child is on regimens with DTG plus lopinavir, double the dose of DTG. There should be, you will have to double the dose of DTG. You need to do super boosting of lopinavir plus ritonavir in the ratio of 1:1. Continue both these medication for 2 weeks after the last dose of rifampicin. So in both the regimens, you need to continue the dose, same dose for 2 weeks after the last dose of rifampicin. And initiation of the second line ART and anti-TB treatment in the presence of TBO infection. So first you need to do these things. The child being identified with first line ART failure, presenting with tuberculosis simultaneously. Anti-TB treatment is initiation is a priority. Second line ART regimen with appropriate modification should be started as soon as possible within 2 weeks of initiation of anti-TB treatment. Now, what are the modifications on DTG-based regimen in CLHIV receiving rifampicin-based ATD? From the previous slide, we can see if the child is on DTG-based regimen, you need to double the dose of DTG, and you need take that dose twice daily for 2 weeks after the last dose of rifampicin. For regimens with DTG plus lopinavir ritonavir, you need to double the dose of DTG and continue same for the 2 weeks after the last dose of rifampicin. And you need to do super boosting of lopinavir tablets with ritonavir in the ratio of 1:1. And you continue both these modifications for 2 weeks after the last dose of rifampicin. So from this pediatric chart, you can everybody must be having this pediatric dosage chart. How to give AL pediatrics, that is 60/30. How to give AL 120, 60, 600, 300, zidovudine based regime, lopinavir based regime. How to do how to take ritonavir super boosting 100 mg tablet for super boosting. And there is so DTC dosing for you can in this you can see DTC dosing for CLHI with drug sensitive TB, that is rifampicin based therapy, weighing less than 10 20 kgs. According to the weight band, in this you need to double the dose. Okay, even double the dose and continue the same regime, double the dose for at least 2 weeks after the last dose of rifampicin. So DTC dose will need to remain twice daily for 2 weeks after the last dose of rifampicin. There is no need to change DTG in drug-resistant TB cases. So now we'll go to the last case. That is, a 12-year-old boy was initiated on zidovudine, lamivudine, and nevirapine-based therapy around 8 years back. 3 years later, he developed zidovudine-induced bone marrow suppression, and hence his regime was substituted to abacavir, lamivudine, and efavirenz, which was available at that time. His CD4 count was 1065, and the percentage was 28%. Now presented with immunological and virological failure, that is, latest CD4 count being 78, and viral load copies being 59 lakh 66,396. The child was referred for the PCSIP. The CSAP recommended regime switch to second-line ART, that is ZLDTG, with close hemoglobin monitoring. As a child, so in this case, you have seen the child was in ZLN. He developed anemia due to that. He was substituted to ALE. And when the child was on ALE, her viral load is too high, that is 59 lakhs. So there is multiple NRTI exposures. So you can see there is zidovudine, bacavir, nevirapine, and efavirenz. So there are multiple NRTI exposure. In multiple NRTI exposure cases, we re-challenge zidovudine if there is current hemoglobin is more than 9 or equal to 9. And if hemoglobin is less than 9 gram per deciliter, we will not change the regime till the anemia is corrected. And if when the anemia is corrected and hemoglobin is more than 9 gram per deciliter, we'll switch the child to zidovudine, lamivudine, and dolutegravir based regimen. So after this, the 3 months after regime was switched to ZL plus DTG, child developed decreased vision in the left eye. On examination, there is no perception of light in left eye. Pupil was mid-dilated and non-reactive to light in left eye. In the right eye, the vision was finger counting at 6 feet. So after 3 months after switching the child to ZL plus DTG, he complained of decreased vision. There was no perception of light in left eye. In right eye, it was only finger counting at 6 feet. Ophthalmologist opinion was done. In this, it showed there is a granular matrix inflammation with extensive hemorrhage and vasculitis in both eyes. In view of extensive hemorrhage component, which is not classically of CMV retinitis, TB workup was done, the VDRL was done. Montauk's was negative, the GA, the gastric lavage for CBNAT and AFB staining were negative. VDRL was negative, the serum ACE level was normal, the CD4 count was 182. So the child had received intravitreal ganciclovir in both the eyes under GA, 3 doses each 7 days apart. Child also received IV ganciclovir for 14 days with close monitoring of CBC and RFP. The prednisolone eye drop were given for 4 weeks. The child was then started on oral valganciclovir for 4 weeks. This is a classic case of iris, that is CMV iris. So her ART was stopped in order to prevent further vision loss. And after 4 weeks, the child reported improvement of vision in the right, but there was still no perception of light in the left eye. So this is the case number 10 is a case of CMV iris. The child had received the oral valganciclovir also. After receiving the oral valganciclovir, the vision of the right eye was improved, but still we lost the vision in left eye. So what are the key points you need to remember? All patients with suspected treatment failure, that is virological failure, should be managed according to the established protocol with timely referrals to CSAP. Early and correct identification of treatment failure is vital in children, especially for appropriate selecting the second line ART regimen. One more point to be noted, the third line drug should be started after referring the child to PCOE or the ART plus center available. And For any second line or a third line regime, you don't need to transfer out the child from one ART center to other ART center, because the second line and third line ARV drugs are available in all the ART centers. In children, there are ARV options are very limited due to dynamic dosing, and poor adherence plays a significant role in emergency of drug resistant and subsequent treatment failures. Early suspicion of treatment failure through routine CD4 and viral load count assessment and regular clinical examination at ART, that is for us symptoms, weight, height, BMI, in ART or ART plus center is necessary to ensure early detection and timely management of treatment failures. You need to ensure correct and complete documentation, registration, and monitoring progress of all the patient referred for CSIP review. There should be regular viral load testing in the children, helps in early identification of treatment failure. In this, everybody knows for the first line ART, you will do the viral load testing after 6 months and 12 months after initiation of the ART. Then you'll do the annually. For second line and third line patients, you do 6 monthly viral load testing. There is enhanced adherence counseling for 1 and 2 must be provided for all the treatment failure patients and documented in the AAC form and filled in white cards. Unnecessary substitution switch must be avoided, and CSAP should be referred to National Guidelines for HIV Care and Treatment 2021 and/or Office's memorandum to decide the regimen for switch or the substitution. So these are the main key points. So I would like to thank all for listening the session patiently. Any questions?
Thank you so much, ma'am. Any questions? Participants have been given mic access. You can unmute and ask questions, or you can put them in the chat box. बच्चों को लेके कोई भी सवाल हो आपके मन में तो प्लीज आप पूछ सकते हैं. Ma'am, I don't think there are any questions. Thank you so much for
Okay.
facilitating this important session.
Thank you.
Thank you.
Thank you, Shweta. Thank you, everyone.
Thank you, ma'am. Thank you to
Thank
all the
you.
participants for patient listening. We'll conclude this session now.